It's already 4 minutes up, so we shall be starting the webinar now. I was just hoping that Navid Babu joins. He has some difficulty as Smita. He said he cannot join. Professor Vitsanu is already been here. And we got the speaker who are very much here. So I think we need to go ahead. And good afternoon, good morning, good evening, wherever you are all over the world. And I'm extremely happy that uh, you all have been able to register for the webinar. I'm told that more than 700 plus people have registered for this particular webinar today. And that's a wonderful news. Today, we are going to discuss about the neuroplasticity, and as a president of Asian Oceanian Society of Neuro Rehabilitation, I want to welcome all the speaker and chairperson, plus all the delegates from all across the world, because this platform has been a very special, because uh, the Asia, which has got more than two-thirds of the world population, our problems are unique, and we are trying to build up how the rehabilitation services and the basics of rehabilitation could be made very strong to not only the neurologists and PMR, but all across the stakeholder of the neuro rehabilitation, be it physiotherapists, speech therapists, cognitive therapists, or others, PMR. So this is a great opportunity for young people to learn and interact. And I think it will be very nice that if you people keep on asking about the question to the speakers. Without taking much time from you, though I've been provided 10 minutes, but I think that it's always good to hear from the speakers who are there. And we got two honorable speakers, Dr. M.B. Padma and Professor Stephanie Clark. Dr. M.B. Padma has been past president of Indian Stroke, and I formally introduced her. She is now the neurologist at Paras Hospital, but she was formerly at HOD at All India Institute Medical of Neurosciences, which is one of the premier institute in the country, as she has been working in the field of stroke. And I particularly know about her involvement in the stroke rehabilitation, particularly to develop low-cost robotic for hand as well as gloves. So she has been very actively involved in neuro rehabilitation, and I welcome Dr. Padma. I would request Professor Vitsanu, who is here as a chair, to kindly introduce our another speaker, Professor Stephanie Clark. Vitsanu, please. Professor Vitsanu is the Secretary General of Asian Indian Society of.
Hello, everyone. I'm Visnu Kamthonthip from Bangkok, Thailand. Hello, President Nemo. And first of all, I'd like to thank the speaker for today. And for the next one is Professor Stephanie Clark. In fact, she is a former president of the World Federation for Neurorehabilitation, the WFNR. She is a professor emeritus at the service the neuropsychology at the Neurorehabilitation School, Lausanne. She's, I think she's very well known of neuro rehab, particularly for the neurocognitive rehabilitation. She's she worked for the WFNR for a long time. That I know her very well. Uh-huh. And today she's talking about neuroplasticity and how to use neurorehabilitation to promote neuroplasticity. And please join us to welcome Professor Stephanie Clark as well. Mm-hmm. Yep.
Thank you, Professor Vitsanu. So I would invite the first speaker of the day today to speak on understanding the brain plasticity. It's a very, very important and complex subject. We were not aware about the plasticity a few years ago. We now know that brain has got plasticity, and we now know that how it can modulate and work in a different circumstances, and also how it can get rewired. To hear from Dr. M.B. Padma Srivastav, we move on to Dr. Padma. All stage is yours to talk about the neuroplasticity.
Thank you so much.
Thank you.
Thank you. And sincere gratitude for this wonderful opportunity to connect with you all. It's a great honor. Now, what I'll do today would be that give you a very, sort of a bird's eye, sort of a synopsis on what we understand as brain plasticity. So this will be from the literature. And subsequently, good part of my talk, I will also tell you about my personal journey, understanding this neuroplasticity and trying to adapt this into the brain recovery processes in our post-stroke disabilities. So the definition of brain plasticity or neuroplasticity is the ability of the nervous system to change its activity in response to intrinsic or extrinsic stimuli. Right? It reorganizes its structure, functions, connections. And, we best understood this, or we tried to understand this after an injury such as stroke or traumatic brain injury. So these changes could be beneficial, like they do restore the function after an injury, which is what we are most interested, or it could be neutral. There are changes, but nothing's happening, which is in your face clinically, or they could have a negative impact. So there are some major mechanisms which have been delineated in this process of brain plasticity, which includes neuronal regeneration, collateral sprouting, which includes concepts such as synaptic plasticity and neurogenesis. There are new neurons being built. And functional reorganization, which includes concepts such as equipotentiality, bifurcation, and diastasis, which we understand very well as strokeologists when we look at happening structural problems in the brain far removed from the site of initial injury. So there are phases or epochs of neuroplasticity, which again have been well defined, like in the first 48 hours, depending on the mechanism of injury, there's initial damage that accumulates as cell death. There's loss of certain cortical pathways, which are associated, of course, neurons, and then the brain attempts to use secondary neuronal networks to maintain that function. And then in the following weeks, which ensue after the initial period, there's a recruitment of support cells occurs in this period as a cortical pathways get redefined. And then there is a shift from inhibitory to excitatory, and the synaptic plasticity, new connections are made. And then onwards, the brain continues to remodel itself, via axonal sprouting and further things. Then the mechanisms of neural plasticity, the first thing is neuronal regeneration or collateral sprouting. Now, the plasticity is the ability to make exercise-dependent, long-lasting changes, which transforms into the strength of neural connections. And this is best expressed with the concept of long-term potentiation. This can be measured. Synaptic plasticity can be positively influenced by several things. The best thing that we understand is exercise. And of course, environment, repetition of tasks, motivation, and then there are certain pharmacopoeia, which helps as neuromodulators, which includes a spectrum of medications. The aging and neurodegenerative diseases have also been associated with a decrease of such neuromodulation, and thereby, that transforms to a reduction in this ability of synaptic plasticity or trying to recoup from an injury. So age has an issue with that. The spike timing dependent plasticity, or the STDP, and this incorporates the timing of action potentials generated by these presynaptic and postsynaptic neurons, and this explains how some synapses are strengthened and others get weakened. The metaplasticity is a concept which includes networks, involves activity dependent changes, and how the synapses respond to it. And hemostatic plasticity are the mechanisms that maintain hemostasis of the synaptic network over a period of time. Then we come to this age-old belief that was always there, that once the brain is an adult, there's nothing new happening. There's no evidence of new neurons development in adults. This was a pretty harsh decree, but this continued for some time. And then now we know that following several of the animal experimentation and this whole era of stem cells have been launched. It's like saying the face of Cleopatra launched 1,000 ships. That's how that it was this discovery that no, this concept is pretty harsh. We do have evidence of some pluripotent cells which are still present in adult, neuronal system, which launched again this great interest in stem cells. So the functional reorganization could be equipotentiality and bifurcation. And quickly, the equipotentiality is a concept that when one area of the brain is damaged, the opposing side of the brain would be able to sustain the lost function. And this dates back at least to Gallup, which sort of brain appeared twinned. This redundancy theory remained until famed researchers like Broca demonstrated that unilateral lesions to an area of left side of brain cause loss of speech, even though the opposing side was intact. And he postulated that the relearning of certain functions, such as speech, were easier for a child than if an adult suffered loss. And this concept morphed into equipotentiality, meaning that if the damage occurred very early, brain has the potential to overtake lost functions. All these are very, very important when you understand the recovery process in a brain after an injury. Now, this is slightly different from the thought of vicariation, which is that the brain can reorganize other portions of the brain to overtake functions that they were not intended to initially. And Broca developed this theory, saying that some of his patients had the spaining of function, even though they had a damage to the left hemisphere. So in the strictest sense, vicariation is when a part of the brain overtakes a new and unrelated function. Now, once we had this advent of functional imaging, a whole new era of understanding the anatomy and physiology of brain. Yeah, all of you would agree with me on this. So, some of this concept got proven using functional imaging techniques. And later on, several researchers were able to show that after a spherectomy, when in epilepsy surgeries, which happen when intractable epilepsies, in a young age, when this is done, the brain can reorganize itself in the remaining half of the brain to restore a lot of lost functions. And this is actually a proven thing. Later, Jailar et al. Were able to demonstrate similar findings in adult patients who had an ischemic stroke of the primary motor cortex. Performing serial functional MRIs, they were able to show the brain was able to show increased activity initially in the bilateral premotor cortex, which shifted over time to right hemisphere supplemental motor cortex. So this shows that the brain is pretty adaptable in trying to organize or reorganize its function. Now, diastasis is a very interesting thing, especially as I said, as strokeologists, we often find a cerebellar problem there when it's a hemisphere which is involved. So this is a concept that damage to one part of brain could cause a loss of function in another area due to some connected pathway and sometimes even not well connected. An example of this is hypoperfusion of ipsilateral thalamus after an acute MC. In fact, the thalamus is not being supplied by that arterial artery, but it still does. And in approximately 20% of acute MCS strokes, this noted hypoperfusion of the ipsilateral thalamus in CT perfusion imaging. Now, trying to understand this, which means that something remotely can also happen when there is an insult or injury at some other part of the brain due to its connections or even some other unknown mechanisms. So the concept of diastasis was broadened over time and is used to explain several different concepts, trying to understand connections of the brain and what ensues when damage occurs. So diastasis at rest, the classic one monocote type such as ipsilateral thalamic hypoperfusion, MCS stroke, or a functional diastasis, this is when an area of diastasis is found when another part of the brain is activated. Okay, so given a functional task of the ipsilateral hand causes this hypoperfusion or this kind of changes in ipsilateral cerebellums, which had no signs of hypoactivation at rest. And then you have connectional diastasis is another concept. And when we get into nitty-gritty into understanding and we get into the depths of trying to understand, it becomes even more complex. Some of them are pretty gray still, and probably with this newer amazing advances in imaging technology which we have now, probably we will better understand what is happening. Like you have connective cone diastasis. Now, with advanced imaging, this was shown that the vast complexity of connections between neurons, a map can be generated called a connective cone. This is now probably not as new as it was when it was first generated. So this map shows clusters of high connected nodes, which are then linked by a limited number of nodes called hubs. So if you have a damage done to a hub, this can cause much more severe damage than a non-hub. All right. So, but as we understand, I think our concepts also will continue to evolve. I don't think we have seen the end of the story yet, and we haven't closed the book yet. Now, let's translate it to what is the clinical significance of trying to understand this anatomic physiologic concepts of brain plasticity. There are several treatment options now which are available to us as we understand, because neuroplasticity will help guide us to institute these treatment modalities. Mirror therapy, I'll come to it a little later. And one of the most studied rehab techniques is a constraint-induced movement therapy, isn't it? This is an age-old therapy. Now, essentially, if you constrain a functional limb, the affected limb is engaged in repetitive practice and behavioral shaping. And using the functional imaging technology, it has been demonstrated that you can increase the activity of the affected side if you will force the affected limb to be used. And that's possible when a normal limb is, curtailed in this activity. So it's particular duration of time. This was a serendipitous discovery, but then this has really grown in its significance. I put up some of these publications that we've had. We have actually grappled with this thing of stem cells. Now, stem cells came as a big hype with a lot of hope, and we know this potential of stem cells is still being explored. And in the meanwhile, a lot of jumping the gun happened, and a lot of usage of stem cells went on to a clinical aspect with no adequate science to back it up. So we thought of getting some good science out of this. So way back in 2010-11, we went into using autologous bone marrow derived both, autologous, what we call as mononuclear stem cells. The other is culture expanded mesenchymal stem cells in our patients with chronic stroke. These were not acute stroke patients, and these are all our publications which we started off in 2011. And we continued to look into the cohort who have received these stem cells. This is a group from our center in AIMS. And we I will come back to this a little later, but quickly, we've also looked at non-invasive brain stimulation, whether it is transcranial magnetic or the poor man's TMS, which we call as transcranial direct current stimulation, which is, it's a portable machine. We haven't had much experience with theta burst. And we also looked into robotics, as Professor Nirmal Surya said, with our collaboration with our IIT, the biomedical engineering brains, the fantastic brains. You give them a problem, then they'll try and come up with some solution. So we looked at the robotic hand exoskeleton using, again, the electric signals and the neuromodulation using these electrical signals to develop that. And then this is a part of, our scientific collaboration. Yes, we were also working on the kinesthetic glove, which is again using feedback, again trying to train the brain and sometimes trick the brain to be able to use the affected limb as effectively as unaffected limb. And we tried to publish some of our understanding. And I said that we had functional imaging, we used the diffusion tensor imaging derived measures to look at the recovery mechanisms. And also we looked at, giving stem cells is all not, trying to replace dead neurons, and so that then they will, release a relevant neurotransmitter, they get into tracks, and then there'll be rebuilding of the tracks. No. We also looked at the paracrine mechanisms. It's probably some kind of a methodology where the neural plasticity is enhanced by making the internal milieu conducive to that atmosphere where the plasticity can happen. So the mechanisms are probably a zillion, but we do not know if one hypothesis works, but probably it is much more than one. And we also looked at our 4-year follow-ups and seen if we have given the stem cells and has anybody developed tumors? Well, they did not. And all this is in published realm. And in the meta-analysis of stem cells, most of our studies have been included into it. And we know that at the end of it all, none of the meta-analysis will give you, a blank check saying that there is a level 1 evidence to use stem cells in stroke recovery. We still have a long road to go on. So all these questions are there, but then remember that when you're looking at a stem cell as a modality, you're again looking at trying to piggyback on our concepts and understanding of neural plasticity. So only time is going to tell whether it's low or high. Then we also looked at growth factors, especially the VEGF. Now, VEGF has a lot of role. The endogenous VEGF gets upregulated after the ischemic event. And we also have demonstrated that if you have a small infarct, you have a little rise. You have a big infarct, there's a big rise. And depending upon how much the rise is, the outcome has been correlated. So VEGF is also being used now as an important kind of, when you give a combo measures to enhance neural plasticity, VEGF is an important parameter, whether it's BDNF or VEGF, some of the growth factors. And then we looked at combos. Let's get exercise. Let's get, the non-invasive brain stimulation along with the growth factors. Okay, so that's an ongoing regime we have. That has been our publication using mirror therapy. And as far as the non-invasive brain stimulation is involved, all of you are well aware of the TMS. This is now in the clinical realm, and it's been a lot of literature, a lot of science, and this is more or less now in the the neuro rehab, whatever be the facility which is looking into the recovery of function after stroke or the TBNs. These are some of our publications using the low frequency repetitive transcranial magnetic stimulation. Now, and then there is a spectrum of pharmacotherapy which has also been tried to piggyback again to help enhance the neural plasticity. All what I've mentioned here are there. But then remember, whatever translates to an animal model doesn't get into, translate into that definitively. You find that benefit in a human clinical aspect. And why is that? We have STAIRS recommendations, they're pretty old. The thing is that when you're looking at animals, there are interspecies variation, confounding variables. I always say that, you can't compare a nubile, young mouse and say that an MC occlusion using a balloon and producing an infarct translates to the same thing of what happens in a human brain. For that, you will need an aged, fat mouse, which also smokes, which probably drinks and has, you want to have that kind of a model, and that's never going to happen. So therefore, the translation is always an important problem. The multiple medications can also be used to influence brain healing. Sort of studied are the SSRIs like fluoxetine, you have serotonin, even duloxetine, and then amantadine and dopamine. Some of these have been well studied, amantadine especially after traumatic brain injury. There's been also a lot of studies on dopamine, SSRIs. Essentially, what people have seen is that you give this, and in the next couple of hours, they seem to be enhanced ability to have that retaining power, and also they're able to remember. And there's an enhanced locomotor mobility when you institute the rehabilitative or exercise regime. So there's been some studies, but the FLAME study later on has not really, the initial FLAME studies were fine, later on they did not, but then it's a work in progress. Music therapy has helped, and also exercise. Exercise has always been a sort of a big vertical on which it is said to improve not just the physical aspect, but also the episodic memory and processing speed. Several dietary supplements, and sleep and diet and reducing stress. Now, reducing stress, I really don't know, ladies and gentlemen, how you quantify stress as such, but it's there. Now, then a word about maladaptive plasticity. See, why neuroplasticity can be beneficial, can also be harmful. So the maladaptive plasticity is when a connection that is made, the brain produces an aberrant or negative symptom. And this has been seen in, for say, examples in writer's cramp, which is a use-dependent dystonia or a phantom limb pain. So here, there's been abnormal primary sensory cortex changes in association with painful symptoms. So sometimes it backfires. This is something which I put up because this is an exciting era that we live in. It is exciting, but it's also a little sort of fearsome, because we do have the machines are becoming much more humanoid and humans are becoming much more mechanistic. So we need to have a line somewhere to get that, a definitive, I know it's a tightrope walk, but some balance there. And all these concepts are extremely exciting. Pain control by neuroimaging, mind control robotics, this concept of connecticomes. And anyone can become a genius if given enough efforts and time. And then you have this communicating with another through quantum mechanics. Probably there's levitation, you can fly on your own. But I know there seems to be endless possibilities. But neurorestoration is an imaging concept still, and I think we have several miles to go before we totally understand and we harness what we know into clinical benefit for our patients, but hope prevails. So never ever give up on neuroplasticity. Thank you. Sir, you're muted. Sir, you're muted.
Thank you, Professor Padma. I think Professor Bauthup has been trying to get in and out. She has been, finally she got it. So Professor Bauthup, kindly put on your video. She's from Laos. She's one of those small country where only very few neuro rehab specialists are there. And I think she along with one or two more neuro rehab specialists are the expert. Professor Bauthup, I'm extremely happy that you are there. Would you like to say thanks to Professor Padma and invite Professor Stephanie Clark as a chairperson for the day?
Okay. Sabadi, good evening for everyone. Sorry to be late based on the poor connection about my internet. So during in the past 20 minutes ago, I still use my mobile data, my mobile phone, but now I cannot catch the voice, but now I start to use my laptop. It seems to be okay. I can catch your voice very well, Prof. Thank you so much for inviting me to join this. Thank you.
Yeah, we can very well hear you now. Thank you very much, though we can't see you.
Okay.
Welcome to our webinar, and I hope that your country would be benefited by these webinar, and I'm sure you will be able to spread this in your country so that the neuro rehab can progress in a country like yeah. Would you like to say in few minutes about the Laos and your country and how you have been working in neuro rehab to our audience and our speakers?
Okay. Prof, how many minutes did you give me to speak? 10 minutes, 5 minutes?
5 minutes.
Oh, 5 minutes. So if 5 minutes, just I can share only the overview of my countries. So thank you so much. I hope that everyone have been visit my country or not yet anymore. In the future, I really need to be invited you all of you to be here. So let me share about my background of rehabilitation medicine very well. When I was a medical student, we never know what is a rehab done. We knew only physical therapists in my countries. Since I met Professor Delisa and Professor Sek from Thailand, Delisa from USA, they organized the meeting on the first ISPIM in Chiang Mai in 1999. So I joined this. So that's why open my eye that rehab is not only one word that we can say. So it's big guess that we can imagine can help every people who suffer with a chronic disease or suffer by disability and etc. So from that point, is burn my dream to be how to be a rehab doctor. So I connect with my professor in Thailand. Then 1 year later, I got the would have been like the not scholarship, but for the graduate, not pay anything. They're support by a professor from Thailand. So I attended for 3.5 years. So from that day, I came back home. If I knew only myself, it's not successful. I have to establish the network. So how to destroy the ice block? Because in the medical society, they doesn't know what is the rehab done. They knew only physical therapy. So that's why I have to expose what is to be done. So on the other side, I work with the expert of orthopedic center very well, because they came from European. They knew what is the physician doctor done for the orthopedic, for the traumatology. So they helped me a lot. So we include not only on the clinical procedure, but we include in the pre-service. That means in medical student in University of Health Science. So I include some topic in the medical student year 5 for let them know about the concept and principle work of the rehab doctor. Then the other hand, I help the physical therapist to upgrading their skill. 40 years they are undergraduate program, but now they have a graduate program for physical therapists. Among 400 physical therapists in my country, they understood now what is rehab, what is the rehab team is needed to work together. They already need now. We work close together with the physical therapist. But the challenge now, how come? Because now I am only one. We have another project with USAID for 1 year. We announce every clinic government hospital to select one candidate to be the short training 1 year for being knowledge on rehab doctor. But they misunderstood. They send the PT, but on the title, we need a medical doctor. Finally, they came, but not on the true goal that we can success. We cannot successful in the aim of the program. Now, I still teach the medical student year 5 and also being an expert on sport medicine with the medical Ministry of Education, and also teach the PT student too. This is the one that a small overview in my country. Thank you, Prof.
Thank you, Professor Bauthep, for giving a brief idea about your country, which is small. I'm sure it will grow in future with your effort. With that note, Professor Vistanu, would you be kind enough to invite Professor Stephanie for her talk of the day?
Yes. The next speaker is gonna be our former president of World Federation of for Neurorehabilitation, Professor Stephanie Clark from Switzerland. She's giving a talk on how rehabilitation can promote neuroplastic change. So please join me to welcome Professor Stephanie Clark. Yeah, big clap.
Well, thank you very much for your very kind invitation. And good afternoon or good morning to wherever you are. It's a great pleasure to speak about these topics. And I'm very glad of the first talk, who was excellent in summarizing the different issues in brain plasticity and neurorehabilitation. My talk, it will be focused on 2 ways in which we can, with our rehabilitation interventions, change brain organization. The first one concerns reinforcing of new or adapted neural pathways. It is based on well-known mechanisms like Hebbian synapses, and one of the aspects has been mentioned in the first talk, constraint-induced movement therapy. I will concentrate on another aspect from the cognitive part, which is the constraint-induced aphasia therapy. The second way of changing brain organization is by changing actual cognitive representations, and this will be my second example. Well, let's go to the first one. Historically, this goes back to Donald Hebb, who has been a very famous Canadian psychologist, and his book on the organization of behavior was really very much influential in understanding how our brains work for cognition.
Ma'am, can you share your screen?
Oh, you can't see it. Sorry, it will come back. I thought you had it.
Go back to the Zoom window and then share screen.
Partager. Okay, do you have it now?
Yes.
Yes,
Okay.
got it.
I will. Okay, I am going back to the first one. These 2 ways of changing with our rehabilitation interventions, brain organization. The first one is reinforcing new or adapted neural pathways. And the second one is changing existing cognitive representations. Now, let's go to the first one, The neural basis of that goes back to Donald Hebb, a Canadian psychologist who described in his book, The Organization of Behavior, mechanisms which underlie our cognition, but also brain plasticity. He has postulated that when the neurons which provide a synapse, the presynaptic neurons and postsynaptic neurons, are active at the same time, their connections will be reinforced, which is plasticity. This type of synapses has been called Hebbian synapse. And this rule of pre- and postsynaptic activity coinciding is the Hebbian learning rule. You all know that later on, NMDA transmitters, NMDA synapses, have been identified as a very important contributor to Hebbian synapses, and that many aspects of learning in the normal situation and after brain injury depends on these transmitters. Now, my example of this reinforcing of existing pathways comes from constraint-induced therapy of aphasia. As you all know, there are different types of aphasia which occur after left hemispheric lesions. From global to anomic, they are very well defined, mostly on the basis of the ability to produce language or to repeat language or to understand language. Naming is disturbed in all types of aphasia. Now, I highlighted on this slide two types. One is Broca's aphasia, which concerns mainly production of language, and by this means also repetition of heard sentences. And in pink, it's Wernicke's aphasia, which concerns mostly understanding of speech. Now, during the last 20 years, neuroimaging studies have shown that there are two distinct networks which underlie language functions. There is one in blue on this slide, which concerns the link from the auditory cortex via the premotor cortex and prefrontal cortex, which is strictly lateralized to the left hemisphere. This is called dorsal pathway. It helps us for phonological representations, articulation, and eventually speech production. Then there is a ventral pathway in the pink, which is partially bilateral in the left and right hemisphere, and which is mainly involved in understanding of speech. Now, in left hemispheric lesions, these networks are disturbed. And in the last 15 years, there have been very influential studies on the recovery, what helps us to recover from brain damage and recover language functions. Basically, I won't going into all the details, but there are two different ways to recover. There are domain-specific networks. This means trying to raise both language networks during recovery, whatever remains of these networks, to use it again. Another contribution is to use what is called domain general networks. These networks are represented on this slide. This is, for instance, the default mode network, which is a sort of reserve network which we can use for internal processes from some thinking processes. But when there is brain damage, it can be used, for instance, for recovery from aphasia. There is one in yellow, frontoparietal control network, which is also called multiple demand system. When we have to do several tasks at the same time, this is the network which gives us the necessary means to it. Then there is another one in reddish, singular opercular network, which supports different functions ranging from emotion, pain, attention, motor control, memory, reward, error monitoring. Very important network. And then there are the attentional networks here in turquoise and in yellow, which are mostly right hemispheric. Well, all these networks have been shown to contribute to recovery from aphasia into different aspects of recovery from aphasia. Now, let's go to constraint-induced therapy. It's also called language action therapy. What is it really? It's used for rehabilitation of language production. And the principle is intensive use of language, and in particular, the use of action words. There is a theoretical underpinning to this approach. I am drawing this from a summary slide by Pulvermiller and Berthier, which they published in 2008. When you hear words which have to do with motor function, like to kick a ball, or to type with the hands, or to click my tongue, it's not only the auditory system which is activated, but also the motor and premotor cortex. And this in a very topographical way, and this is represented here. The left figure shows the activation by the actual movements, finger movements in red, foot movements in blue, tongue movements in green. And as you noticed, this is exactly the homunculus, the topographic representation of the body parts. Now, hearing the words which describe these movements co-activates partially these same areas. The idea of language action therapy is the treatment intensity, but also to reinforcing this link between language and action. How does it work practically? You have usually groups of patients and they sit around a table, they have cards, identical cards, and they are forced to communicate by speech only. They need to have some ability to produce speech. And one says to the other, "Do you have the card with a yellow flower?" The other person says, "Yes, I have the card with the yellow color." The first patient says, "Please give me your card with the yellow color," and so on. And this massive repetition leads to improvement in language production. The graphs below show it, the effect of 2 weeks interventions. Now, there are several studies on the activation studies on the effect of that. And here is one of them published recently. And what you see there in pink is the increase in activation induced by this constraint-induced therapy improvement. There is a correlation between this involvement of the precuneus, of a part of the left hemisphere, and speech production. You may remember that the precuneus is part of these networks which can be used for recovery of aphasia. And here is a proof that this massed practice indeed included this network into the language production network after stroke. Said that, The effect can vary between patients. This is another study where they investigated 16 patients with a non-fluent aphasia, meaning Broca-types aphasia. The patients improved after constraint-induced therapy, and they used in an increased way the right inferior frontal and temporal areas. However, there is a great variability between patients, and this is illustrated by the three examples. These are three different patients from this study. Thus, the individual configuration, probably also configuration of the lesion, impacts the brain reorganization. That was the first aspect of how we can act on brain reorganization. The second one consists of changing actual cognitive representations. And we have to consider a facilitating effect which is there after a brain lesion occurs. My eminent colleague in her first talk was speaking, introduced the topic in a very general way, but I will go to something much more specific. Animal studies where focal brain lesions, these are stroke models, have been done, have shown that within the normal cortex, which has not been damaged in the hemisphere ipsilateral or contralateral to the lesion, there are widespread changes in transmitter receptors. In particular, there is an increase in NMDA receptors. You remember NMDA, this is the plasticity receptor which facilitates Hebbian synapses. On the other hand, there is a decrease of GABA-A receptors, of the inhibitory synapses. This means that there is a receptivity for remodeling. This is a general predisposition. And this is so even in the human brain. These were animal models on this slide, summarized by Professor Nudo and his colleagues in a review. We have looked into that in human post-mortem brains, and we have compared GABA-A receptors in the cerebral cortex, the intact cerebral cortex, and compared brains where there were focal stroke lesions and normal brains. And there is indeed a decrease in one of the GABA-A receptor units in parts, in the deep layers of the cerebral cortex. This means that this situation of this febrile situation is also present in our patients. Now, let's go to a specific reorganization which we can induce with rehabilitation interventions. For this, I will use as model neglect, unilateral neglect, which occurs after generally right hemispheric stroke. Neglect is a disturbance of the attentional system. Now, back to the attentional system, it has two parts, which are in blue and orange on this slide. One is the ventral attentional network, which is mainly lateralized in the right hemisphere. You see on the figurine below, which comes from a review by Corbetta and Schulman, or on a schematic representation which we published, which is based on Silver and Kastner, 2009, and Koch and colleagues, 2012. The right hemispheric ventral attentional network helps to reorient attention to environmental stimuli, like visual stimuli, auditory stimuli, other types of stimuli, and is localized mainly in the inferior parietal lobule and the superior temporal gyrus, meaning temporal parietal junction, and the prefrontal cortex, very predominantly on the right side. There is something very small on the left side. This means there is a whole space representation within the right hemisphere in the ventral attentional network. The dorsal attentional network helps us to orient attention where we want to. I think there might be something on the right side, and I can orient my attention there, or to the left side. This attentional network is localized in the superior parietal lobule and the intraparietal sulcus. It's very symmetrical, and within each hemisphere, it's concerned with the contralateral space. This is represented in the blue. Now, what happens in neglect is generally the destruction of the ventral attentional system in the right hemisphere. This creates a disequilibrium between the two parts of the dorsal attentional system, and the one on the left side inhibits whatever is left on the right side. You see the red arrow, which became very thick and inhibitory. Now, one of the therapies which has been shown to be pretty successful is prism adaptation. In this therapy, which has been introduced by our French colleagues, Yves Rossetti and Gilles Rod, over 25 years ago now, for neglect, the subject wears a prism goggles, like on the slide, which introduced a shift towards the right. Everything the subject perceives, it's shifted to the right. And in this condition, subject is asked to point towards target. This is represented in the top line. Without prisms, no problem in pointing. When there are prisms with a deviation, the first pointings overshoot to the right, but very rapidly each subject corrects. When we remove the prisms afterwards, the subjects overshoot to the left. This is the so-called after effect. This is the situation in normal subjects. Our French colleagues did use that in patients with neglect, and this is the example from a patient on the left side, at the bottom left. One of the tasks in neglect is a copy of a small scene. Before prism adaptation, this patient copied things more or less correctly, but all only on the right part of the drawing. After prism adaptation, very progressively, he improved his performance and copied 2 hours afterwards almost the whole picture. This exposure alleviated neglect symptoms. And there are other publications which I do not have time to go into, which show this effect also on the long run. Now, what is happening in, what does prismatic adaptation do to the brain so that it improves neglect? I will present you the short version and start with our work, works especially by Sonia Crotta-Herbet, who is on the photograph here, in collaboration with Claire Binchedler, the clinical partner of it. What Sonia did was to look in how the attentional system is organized before and after a brief exposure to prism adaptation. And the task I will be reporting is one which is known to drive the ventral attentional system. These are flashes, visual stimuli presented on the right or left side or in the center of the visual space. Basically, these brief exposure changes the dominance of the right dominant ventral attentional system from the right to the left hemisphere. This is the case in normal subjects, but also in patients with right hemispheric lesions and neglect. Now, when we summarize it in a schematic representation, in normal subjects, before this exposure, we have this whole space representation within the right inferior parietal lobule. And after it, we have also a bilateral representation within the left inferior parietal lobule. This is the case in patients with right hemispheric lesions where the right dominant ventral attentional network has been destroyed, and now there is an alternative network in the other hemisphere, which has been raised very rapidly, raised by prism adaptation. Now, this alternative ventral attentional network in the left hemisphere can drive what remains of the dorsal attentional network in the right hemisphere, and this leads to the recovery of from neglect. Now, you may wonder how this happened. How can we, within a couple of minutes, raise a completely new representation and use it in rehab? Well, there is one hypothesis which we summarized in a recent review. Basically, what you do by putting the prism, right deviating prisms, and then asking the subject to point, you force the use of one hemisphere or the other. Basically, in this situation, your patient will never point within his right peripersonal space, because by correcting, he needs to do it to the left side. This means that the left hemisphere, all the parts in the posterior parietal cortex which are involved in visual motor coordination, will be underused, and their connections will be reshuffled, changed. And this change facilitates the reappearance of alternative spatial representations which are already there. Now, going back to this schematic representation, this happens also in patients and can lead in recovery. But seeing this green arrow in the right figure on the right half, you can imagine that some patients may respond to this treatment and some don't. You can guess what is necessary. What is necessary is this access from the left inferior parietal lobule to the right dorsal attentional network via the corpus callosum. This has been confirmed in behavioral studies. We have analyzed anatomical profiles of responders versus non-responders to prism adaptation, and two other groups, Goddard and Gutierrez and their colleagues, have did the same, and all three groups have concluded that we need this posterior part of the brain be intact so that the callosal axis is preserved. This has been also confirmed on the basis of our hypothesis by colleagues from Geneva, who have shown that only patients who have anterior lesions but not posterior lesions which interrupt the corpus callosum pathway, can raise after prism adaptation the dorsal attentional system. Basically, this second example shows that when we use certain rehabilitation intervention, we can very specifically change brain organization in some systems. Now, how to include this knowledge, and not only the specific knowledge, but the general knowledge, to our clinical practice and to design of clinical trials? Well, basically, this is a view on our lake in winter when there is fog and below, but from the mountains you can see the details. Basically, very often we are like that in rehabilitation. We know that there is something which we would like to use that we do not understand precisely. I think we need to go further. Even for our clinical practice, we need to understand brain mechanism underlying cognitive functions and their recovery after brain lesions. We need to understand who are the responders and non-responders for the interventions we are using. And then we need to use the right therapy for the right patient. It comes to precision rehabilitation. For instance, prism adaptation used in a patient with a posterior lesion who has an interruption of the callosal pathway will most likely not be successful. Other approaches need to be used. For the randomized clinical trials, it's also a very important criterion, because we need to describe very clearly inclusion and exclusion criteria for these functions. Because imagine you have population of patients with neglect who have all sorts of lesions, and you apply one treatment, prism adaptation, to all of them. Among this population, you will have responders and non-responders, and it is very likely then at the end there won't be a positive effect, because the inclusion criteria, the responder criteria, have been not defined. This is the point I was wishing to make. There were two examples of constraint-induced aphasia therapy and of prism adaptation in neglect, but there are many more examples which are now known, where the responder and non-responders profiles start being understood, and we really need to take this into account. Thank you for your attention.
Thank you so very much. It was a wonderful, wonderful lecture. Sanu, over to you.
Yeah. Thank you, Stephanie. Yes. May I have a, I don't know, you have a question from the chat box or not?
Chat
No.
box?
No. Okay. So during waiting for some question, I think we have some times, right? May I have a question to I think both speaker you can answer. I'm curious that if neuroplasticity get a Pareto, can get a Pareto, and what kind of factor influence on the neuroplasticity and outcome?
May I refer to the first speaker?
Yeah.
So, okay. I'm sorry, I'm actually in the clinic, so I was also in between. I had to see the patients. So the question you were referring to, Professor Kumta, is that you were saying that when the neuroplasticity hits a plateau, then what do we do? Is that what you're saying? Now, it's a wonderful question. I wish I had an answer to that. But as far as the literature, that whatever we have so far, the question of plateau is only arises, I guess, which is there is a time-bound understanding of the plasticity mechanisms which unfold after an insult. So when the epochs or the timelines have been defined, like in the first 48 hours and the first few days and first few weeks, and we also correlated to how, say, for example, a post-stroke recovery, we look at the disability scoring system also at a timeline of 3 months, 6 months, or at the most 2 years. But I suppose there are always outliers. You know, as Professor Clark also said, that, you know, you putting everything into one glove fit all approach and put the entire gamut of even our understanding of the timeline of how long or how, you know, when does this plasticity concept just end kind of thing. I don't think we know that. So, but we largely know that in an umbrella that we have these epochs defined, but I'm sure there would be outliers wherein this epoch may just be a couple of weeks and they will just hit the, you know, the rock bottom, and they're not going to improve. And there would be people even beyond a couple of years, they continue to evolve and respond and have plasticity mechanisms. But largely, I think it is a matter of clinical improvement we gauge over a period of 2 years. And that's how, you know, whether it is a recurrence of an event or assessment of a, you know, all our EDLs, whether it's in whatever way, whether it's Bartle or MRS, you are at the end of 6 months and, you know, most of the assessments are there. Thinking that the plasticity along with the internal milieu and your external structure would be maximum there. So that is what we understand, but I don't know the answer. You would probably, you know, I'm a clinician more than, you know, a rehab person, but that's what I understand, sir.
Okay, thank you. So nowadays, thank you for your answer. Nowadays, in the era of precision medicine, and like in many neuro conditions, some talk about the genetic. So like BDNF polymorphism, like 66 valine 66 methionine polymorphism, like that, or other. You think is you have evidence that is influence on the outcome or recovery or in terms of neuroplasticity or not? And you have evidence to show that?
This is a very important question and a very correct one. When you look into that, the genetic approach in neurorehabilitation may be very difficult because you have a great variety of lesions, you have a great variety of premorbid conditions in your patients, and you have a reasonably great variety of therapeutic interventions in the patients. Even if they have no therapy, they may be exposed to different types of environment after the brain lesion has occurred. Now, when you talk to our colleagues, geneticists, they love to have huge numbers of cases, really big ones, and they need to be homogeneous. Even if you go for single gene hypothesis, like you said, BDNF polymorphism or ApoE polymorphism and things like that, the variability of the other aspects may impact the analysis. It's very difficult. It would probably be necessary to have some additional arguments, like saying it promotes reorganization or something like that. it's not, genetic is not easy, although it plays most likely a very important role.
Okay.
Thank you, Vitsanu, for two very interesting questions. We've got a couple of questions. There is Mr. Sarkar who has asked Stephanie Clark, can you please again explain how can we do CIMT for language function and the prismatic adaptation?
Okay. Well, the constraint-induced motor therapy, I'm really not the specialist. Prism adaptation is a pretty straightforward procedure. You need to have sort of glasses which have a prismatic wedge inserted, which is something like 10 or 15 degrees. Originally, it was sold very expensively by French opticians, but we have realized that we can have it pretty cheaply done by any optician. And then you expose the patients. There are publications which describe, by our French colleagues, which describe precisely the different parts of the setup. But for constraint-induced motor therapy, can I hand to you, Professor Padma Srivastava? Probably you use it more than...
So we use the constraint-induced movement therapy for the recovery of the motor functions, not the speech part of it. In fact, the speech rehabilitation in the realm of the speech and language pathologists and speech and language therapists, what we call as SLT and the SPT, within the country, in fact, is a growing field, and Professor Surya would agree with me on that there are pockets wherein it is pretty much far advanced, but it has not gone into all realms of clinical practice. That's a gray area. And we have to learn a lot from you, Professor Clark, as far as the cognition and the aphasia part in the language function is concerned. So we are not using CIMT in the language recovery.
Okay,
CIMT is precisely being used, as far as my experience goes, is in the recovery part of the motor deficits.
Yeah, I thought about the motor recovery using the forced use of the paretic hand.
Yes.
Now, this constraint-induced aphasia therapy, as I described, this is a forced conversation in patients who are non-fluent. Yeah.
So in the CIMT procedure is very simple, and in fact, it's just that you for periodic intervals, as much as the patient can tolerate that procedure, you forcefully not use the able limb or the able hand, which is what we automatically do when we have to use something. So it is a forceful limitation, and for intervals which the person can tolerate, and then you increase that.
Thank you.
So just light up my question a bit related to speech. I in some patient with motor aphasia, if some they can singing, so can we use like a music or singing as a forced use to recover the speech?
Yes, this is melody intonation therapy, and this has been introduced in the 80s and 90s, and there is good evidence that it helps to recruit left hemispheric networks. The indication for that is defined behaviorally are patients with Broca's aphasia, but to be excluded, patients with global aphasia, which usually do not respond. And basically what you do, the patient who can't say something, you ask him to repeat, "I would like to eat." The patient is there, can't say, and then they start with a melody and sing it, and the patients can sing. It's striking because we had patients who could not speak at all. They said yes, and nothing else. And then started this melody intonation therapy, it helped. And before they were speaking, they took up singing in their choir, singing. And that was moving. And they recovered the recovered language is not perfect. There is often agrammatism and other aspects, but it helps. But again, there are responder and non-responder profiles to this therapy.
Yeah, that's the way that I suggest my patient to do a karaoke, so singing. Yes,
Very
okay.
good.
All right, thank
A
you.
couple of more questions here. What can be the research area in physiotherapy point of view? And well, we all can answer that, but Professor Stephanie Clark, could you guide that? How they do the, for a physiotherapist, how the research part can be done for the
Okay, let me comment just on neglect. Neglect is, of course, concerns the awareness of the space, but also posture. You have something like the pusher syndrome, which is often associated, and other difficulties, like patients do not put the same amount of weight on both feet and so on. Prism adaptation and other interventions can improve that, like stimulation, TMS, or other aspects. But for this, it would be very important, again, to look into responders and non-responders, because partially it depends on the same network as the attentional aspect of neglect. But I would like to refer to the first speaker for that, because I am not a specialist for motor rehab.
Oh, you said it all, Professor Clark. You said it all. I think we can move on to the other question. I think there are a lot of questions now.
Okay.
And we have just 7 minutes.
Yeah. So we got a couple of more questions. Do you have more evidence-based studies on the neuroplasticity, which will have a huge effect on neurological diseases and the way of rehabilitation process by Mr. Ali?
No, but that I think is could be disease specific, as well as you can have a more broad view on it, or also extremely disease specific studies. And I think it's a huge minefield there. And if you actually dig into it, you'll find scores of studies which are looking into individual aspects, as well as a broad overall benefit in terms of broad disability scales. So if you just take stroke rehab, there are a zillion of those going on. And if you take the basic sciences aspect of the recovery processes, just take neural plasticity, that's a whole new, just reading about it in the last couple of weeks, I found so much on the published domain. So there's a whole lot of thing which is trying to gain science and evidence into understanding, interpretation, and eventually the practical aspect of what modality to give to what disability, post-stroke as well as after traumatic brain injury. There's a lot of evidence-based science which is going on.
Perfect. I think the Pushparaj has one question. Low and middle income countries, the penetration of technology is limited, and the country has used financial constraint. So rehabilitation strategy for individual, considering this situation, how do you think that this technology through the mobile phone or app should be working? Yes, Stephanie.
I would propose to attack this question on two different levels. One, which is very important, is to be very clear and outspoken that for each therapy there are responders and non-responders, and to spell it out for the politicians in the country. Because your health system will want to be extremely efficacious, and they would like to use only things which were proven in randomized controlled trials plus meta-analysis. And you may have noticed that in neurorehabilitation, there is a profusion of negative studies which did not consider that there are responders and non-responders, which is a methodological problem. And you need to make sure that your politicians and decision makers understand that. Not that they say rehabilitation, neurorehabilitation doesn't work, let's forget about it. First level. The second level, it is very important to translate what we know into something which is feasible in the setting where you want to act. Because all this knowledge can be translated into something much more practical. You need to understand what is available where, who are the people who would be administering it or not, and how to communicate. It depends very much on the context, but this is feasible. But this is another question. I think that the first point is very important for the future.
Yeah. All right. So there's a Aman who wants to know, can we combine music therapy and MT protocol together to get better outcome? I suppose so, but any thoughts from you?
Yeah, combos are always now the way forward. I mean, you are combining strategies. In fact, when as Professor Clark so beautifully told about responders and non-responders, so when they're actually one way of trying to probably get more people into the umbrella who may respond to some extent, has also been this combo technique. Again, no evidence or big science to stake the claim on that kind of approach. But especially in a low-income strategy, and when you have a dearth of real evidence or try to prove who will respond versus who will not, using low-cost strategies, these combination techniques using tele-rehab, of which Professor Surya is probably the pioneer to use tele-rehab in India, along with strategies which are low cost. So music and the traditional methods of using music. In fact, in India, there's been attempts to just have the recital of Gayatri Mantra. There are these traditional, singing techniques which have been used, and the usual chants which are in the prayers, and trying to harness the right hemisphere to take over and some function. And all these in combos are being tried, and these aspects need to be studied much more in detail in a more robust way, but they have their more challenges, as Professor Clark said. But yes, this is being done in certain areas in the country.
Perfect. And those who are interested in music therapy, Professor Michael Todd is going to be in India on 28th and 29th of July in Mumbai. And we are having 2 days live workshop. So where you keep looking for the registration, there are limited number of registration will be available. It will be in Mumbai, so you are most welcome to attend that. And I think we take the last question, Professor Stephanie and Professor Padma. It's from Mubarak, who says stroke recovery is critical within first month after the stroke. That's very right. And neuroplasticity is a key for recovery of neuronal function after stroke. Absolutely. Do you think research into ways through which neuronal environment could be made to respond and have enhanced neuroplasticity throughout lifetime can help in stroke recovery, especially in chronic stroke? I suppose so, but I think this is about the future. You need to put some battery inside your brain, keep on stimulating the brain and creating the loop. And batteries would be the more than lithium battery, which continue to fire rather than the expiring battery. So question is open, very interesting.
Yeah, sure. But the same thing that I think most of the enthusiasm has actually been initially with an acute stroke, because that's an internal milieu which is very conducive. The host is also mounting this defense mechanism and trying to mount this, like, you have real big upsurge of VEGF, which is going on, and it's a huge, big biomarker for plasticity. So you have that milieu there. At the same time, in the acute stage, the internal milieu is also hostile. You have excitotoxicity, you have inflammatory mediators, you have an apoptosis which has got kicked in, so you have the programmed cell death which happens anyway. So, you have a milieu which is hostile and a host defense system which is maximum. So balancing this out, most of the interventions, whether it is stem cells, whether it is, any of these methods of giving growth factors and combos, have come in acute. But at the same time, chronic stroke was taken as the, that is a cohort where the milieu is quiet. You don't have to deal much with it, but you can harness the reparative mechanisms by other means. That's also been there. But then happily marriage tends to, where we need to see optimal time and strategy. And the question here is, if you can harness it, how can you prolong it forever and keep harnessing and not have a timeline of neuroplasticity? That, my friend, is something that I guess you will get a Nobel Prize if you find that answer. But I would say that most interventions are targeted towards acute stage, because that's where the milieu of defense is maximum. And plasticity, the epoch, the first couple of weeks is where the timelines are maximum for recovery. That's where they want to piggyback to put in whatever strategy you have, maximize recovery as it exists, but I'm sure it'll change.
Okay. Any thought from you, Stephanie?
Well, it is a very optimistic question, and I think we will know more in 5-10 years' time. We just need to be aware of it. And I think the collaboration between basic neuroscience and neurorehabilitation is of utter importance, as said in the first talk. Yeah.
Thank you. Asmita, would you kindly put the slide for the next webinar on 4th July? I think it's a wonderful session. Vistanu and Joy will agree. We are really, really excited and heard a very knowledgeable talk, both of the speakers, Dr. M.B. Padma and Professor Stephanie Clark. And we continue our journey every month, first Thursday, 3 o'clock India time. So you know that you can block your timing. And the next is innovation in assistive technology for neurorehabilitation. And we will have cutting edge rehabilitation by Professor Wonso Kim, and real world application and success story by Abhishek Srivastava. So these two guys working on robotic. We always welcome if you have any suggestion to write to us, and your suggestion can improve the quality of webinar, and even the speakers can some interesting case on robotic and want to have a case-based presentation for 10 minutes, you may write to me on my email, and I would definitely try and see if that case can be included. Anything you want to add, Professor Joy or Vistanu?
Yes, I think this is a very wonderful Zoom webinar. Yeah. And very interesting, and we can enlighten many idea in neurorehabilitation, particularly for neuroplasticity. That is a like solid basics in neurorecovery and neurorehabilitation. I'd like to thank two speakers, Professor Padma and Professor Stephanie Clark, for joining us and give us a wonderful talk today. Thank you so much.
Yes, congratulations to the wonderful speakers. Congratulations to this webinar. And bottom line is, we learned from these sessions that we should move, think, talk. And that's the only way that we can recover from a stroke, though recovery is complex, and it's so nice to always discuss recovery from stroke, as we are going to affect so many millions of patients who have stroke and we are offering hope for our stroke patients.
So thank you all, and I look
Thank you.
forward to have you again on 4th of July. I know the questions will keep on coming, but we will continue to have discussion. Anything else we will have on email. Thank you and bye-bye.
Bye-bye.
Thank you.
Okay, bye-bye.
Bye.
Bye-bye. Bye, Stephanie. Bye,
Thank
Nhung.
you. Bye-bye.
Bye-bye, Joy.